Alright guys, let's get busy talking about opioid classification. This is going to be really important on test day because step 1 loves mechanisms. So let's go ahead and get into it talking about our agonists, which I'm going to highlight in red because these are all full agonists. I'm going to start with these top 3, morphine, fentanyl, and hydromorphone, also known as Dilaudid. And I'm starting with these because they are full agonists that don't really have any other special qualities on test day. But in terms of the mechanism of these 3 drugs, it's just important to know that they are full agonists and that they're really useful for pain control. Now, moving on to talking about codeine. Codeine is special because it's an antitussive. So we know that opioids have antitussive properties, and codeine is a great one that we like to choose on test day when it comes to questions about antitussive effects. Next, let's talk about tramadol, which is a really great opioid for chronic pain. And the reason why it's good for chronic pain is because it has some SNRI activity, so sort of some antidepressant-like effects that are going to help our patients who are dealing with the depressive associations with chronic pain. Next on our list is going to be meperidine, which is another full agonist that is useful for pain control. However, the unique thing they like to ask about here on test day is that instead of meiosis, we're going to see mydriasis, which is going to be the pupils that are going to be expanding over a normal limit. So normal would be around 3 to 4 millimeters. Someone on meperidine might have closer to 5 or 6 millimeter pupils, which is strange because we usually expect pinpoint pupils with all the other opioids except meperidine. Lastly, let's talk about methadone, which is a full agonist as well. It has a really long half-life and it kind of has a slow onset of action. So you can think of it as like a really slow build-up and long sustaining opioid. And this is great for people who are on opioid replacement therapy, who are trying to wean off opioids if they are addicted. So we use this for maintenance and weaning purposes. And like I said, it has that slow onset and long half-life. Moving down the list, let's talk about our agonist antagonists here. We're going to highlight these in orange because they have properties of both agonism and antagonism. So why is this important on test day? Well, the reason is that these 3 drugs that we're going to talk about here all have the ability to kind of crowd out the opioid receptors and prevent anything else from sitting in there. So imagine you have a patient on a really high fentanyl dose. They're getting intense, full agonism at that receptor. If you were to give them something like buprenorphine, that buprenorphine is going to knock all the fentanyl off those receptors and take its place. And it's going to give some minor agonism, so it's going to give a little bit of opioid effect, but it's not going to be nearly the amount the patient is used to who is on the full agonism of a hefty fentanyl dose. So it's really interesting because these drugs are useful for weaning patients off of opioids because we're giving them some opioid agonism, but we're taking away that full agonist effect and we're preventing any other opioids from sitting on that receptor. So that's why we can give them for pain control and also for maintenance, because if you're giving someone buprenorphine, they cannot get agonism from a full agonist like, let's say, Dilaudid, which is the hydromorphone that we mentioned earlier. So importantly, this can cause withdrawal symptoms, so you have to be careful. If you have a patient that's in full agonism and you give them buprenorphine and be like, oh, they're going to be fine because it has some agonism activity, that might not be the case. It might not be enough for them to feel comfortable. So it's a really tricky game in terms of titrating this, and on test day, they like to quiz you about why a patient might be experiencing withdrawal syndromes on buprenorphine when it has agonism activity. And the answer is because it's a competitive antagonist that is booting off all other strong opioids at that receptor. Pentazocine and butorphanol also have this mechanism of action, but they're largely more used for pain control rather than maintenance, whereas buprenorphine is our main agent that we can use for both pain control and maintenance. All right, let's move on to talk about our full antagonists here. So these agents only have antagonism activity, and the reason why I'm highlighting them in yellow is because if you combine yellow and if you combine red, antagonist with agonist, it's going to give you an antagonist agonist, which is orange, and red and yellow make orange. So that's why I kind of did this for you guys. Our 2 agents here are going to be naltrexone and naloxone. Now these sound super similar. They both start with N. They both have X's in there. It's important that you guys know the difference between the 2. And I'm going to give you guys a little mini mnemonic how I remember it. So naltrexone is all about longer term opioid antagonism. So it's a long-term therapy, and you'll notice that naltrexone is a longer word than naloxone, whereas naloxone is for short acute therapy. So you'll see that naltrexone is used for relapse prevention. So it's a drug that you give someone every day to make sure they're not going to relapse, because if you have that antagonist, they're competing at the opioid receptor, they're not going to be able to get any opioid agonism if they decide to use opioids. Now, let's talk about naloxone. This is a drug you give when you have a patient presenting with respiratory rate of 5, pinpoint pupils, completely somnolent. It's an acute intoxication rescue. And remember, the word naloxone is shorter than naltrexone, and it's for short acute interventions. So that is the difference between those two. They're super similar. Please make sure you guys keep these straight on test day. Additionally, naltrexone is useful for alcohol and nicotine addiction. So if you have a patient who's trying to get off of alcohol or trying to get off of nicotine as well as opioids, it's a great option because it interacts with the opioid receptor, and that also has effects on our craving and our dopamine reward tract for how we crave alcohol or nicotine as well. Lastly, let's talk about our other category, which I'm going to highlight in pink. And let's start off by talking about dextromethorphan. This is going to be used as an antitussive. So if people have a cough, they can go ahead and go to CVS or Walgreens and pick this up, and it's going to be great at relieving their cough because we know that opioid agonism can reduce the cough reflex. Now, have you ever noticed that if you go to buy cough syrup at CVS or Walgreens, they ask for your ID or they have to unlock the cough syrup with a special key? This is because it has opioid agonism that can cause euphoric feelings that may cause someone being addicted to opioids. So they don't want someone to just go ahead and buy 10 bottles of cough syrup and abuse it the wrong way and not necessarily use it as an antitussive. So I hope that is a way for you to connect that opioids have antitussive properties as well as euphoric and pain relieving properties. Now, let's talk about loperamide diphenoxylate. And this is a really interesting drug because we know that opioids have receptors along our gut. And when these receptors have agonism, it causes the gut motility to slow down. It can also cause sphincter of Odi spasm. So we know that our opioids can cause this slowing of gut motility, and this is really useful in a patient who has diarrhea, because when we have diarrhea, we have this rapid pass of liquid and stool that is going through the colon, and there's not enough time for the colon to absorb all of that water. So if we use an opioid to slow that motility, the colon has more time to absorb water, and it's going to create a firmer stool, and it's going to help relieve those symptoms of diarrhea. Now, you might be wondering, does this also cause these euphoric or addictive symptoms? And the answer is no. When you're at the CVS, they don't care how much loperamide diphenoxylate you buy. They don't unlock it or make you have a limit to how much you can purchase or show ID, because this drug does not cross the blood-brain barrier. So people are not going to try and use this to get euphoric effects because it's not going to get to their brain. So they're not going to feel that. It's not going to be an addictive medication, but it's still going to be really effective for diarrhea. So I hope that remembering that loperamide diphenoxylate does not cross the blood-brain barrier can help you with the association of needing to show ID at the drugstore to buy dextromethorphan, but not loperamide diphenoxylate. And this is a great way to highlight the adjunct uses of opioids aside from pain control.